Hi, I'm Dr. Yee Kok Meng, consultant interventional cardiologist working at Pantai Hospital Kuala Lumpur. So when we talk about aortic valve stenosis, which happens usually in the elderly, the valve becomes very tight and restricted. The heart will struggle to pump, and that will eventually cause symptoms like chest pains, and the heart will eventually fail and they go into heart failure. And patients may have poor cardiac output, and that may lead into patients having dizziness and fainting spells. So if patients, for example, have symptoms of heart failure as a result of aortic valve stenosis, the median survival is only 2 years. That means if they don't get treated, 50% will die within 2 years. It's actually not an uncommon disorder. It is quite common in the elderly. 5% of patients above the age of 70 may have some degree of aortic valve stenosis. But not all patients may require surgical treatment. In mild cases, you can get away with just medical therapy. But as the aortic valve severity gets worse, and it comes to a point when it becomes symptomatic, then they require treatment. In aortic valve disorder, it can happen to anyone. It happens with age, when the valves degenerate. Of course, you can do certain things like a healthy lifestyle, keep your cholesterol low to reduce your risk of cholesterol deposits, and which may lead to calcification. But actually, it's not really a condition that is driven by lifestyle. It's mostly either degenerative or due to previous inflammation or damage to the heart valves. The aortic valve stenosis does differ in severity from person to person. In mild cases, you can actually get away with just medical therapy and regular monitoring. But then there are those where the valve is quite thickened and quite calcified. And so it's very restricted in its opening, and the heart really struggles. And in these patients where it's very severe, we monitor them and they come to the point when they become symptomatic, then there's an indication for treatment. And the main treatment for aortic valve stenosis is basically to replace the valve. And you can either do this surgically, which is the traditional way of treating these patients. But increasingly, we are now able to offer an alternative solution, which is what we call TAVI, transcatheter aortic valve implantation. It's a minimally invasive procedure where the aortic valve is replaced through basically a tiny incision in the groin, where we pass a catheter that delivers the valve into where the damaged aortic valve is, and we deploy the new aortic valve prosthesis in replacement of the old valve. It can be done under sedation or under general anesthesia. It's a procedure that will take probably about 1.5 hours to 2 hours to do. Because the incision is relatively small compared to, for example, open heart surgery, the recovery time is fast. Patients are often discharged after 1 to 2 days in hospital. After a week, they can get back to their normal activities. So quick recovery time, quick downtime. So it's much easier and to some extent a safer procedure than going with the traditional surgical aortic valve replacement. The important thing about the TAVI procedure is actually having the right patient selection. I think that's very important. Because you see, not every patient with aortic valve stenosis may be suitable for TAVI. So a lot of the groundwork that we do before we even take the patient to the table is actually making a proper assessment of the patient. And that means doing a couple of tests. I mean, obviously, the echocardiogram is essential to determine how severe the valve is. It's also important to assess whether the heart is strong, which gives us an idea about the risk involved in the procedure. Then they will need to do a CT scan, a CAT scan, a CT scan, not just of the aortic valve, but also the entire aortic tree, the arch. You have to see the access across the aorta and the blood vessels down to the lower limbs. Because the procedure involves passing a catheter through the aorta right up to the arch. And that is actually quite a big device. So we have to make sure that the patient has blood vessels that is able to accommodate these big devices. So we have to do a CT scan of the entire aorta, the thorax, and the groin. And we have to do a coronary angiogram as well to look at the coronary vessels, whether there's any concomitant blockages. Because if there are, then we have to clear the blockages first by angioplasty before considering them for TAVI. So quite a lot of criteria that we have to, when we go, a checklist of things to see whether they are suitable. So once we've decided the patient is suitable for TAVI, and of course, then we will preempt the patient and discuss with them about the ins and outs of the operation. And it's virtually a painless procedure because before they go back to the ward, the sheath are all removed, and we have to close it out with some closure device. So hopefully that will seal up the wounds and they won't have any bleeding complications. So that's why we have to monitor them closely for the first 24 hours before they get discharged. The thing about aortic valve stenosis is that the landscape has changed over the last few years because TAVI has really changed how we manage these patients. It offers a lot of these elderly patients safer alternative than going through open heart surgery. So I think it's worthwhile if you have this condition where you have a tight aortic valve and your clinician says that you need treatment, it's worthwhile getting a second opinion. Because one of the things is that not many centers actually will offer TAVI. We are probably one of the very few cardiac centers in Malaysia that actually has that. So it's worthwhile knowing the options. If you were to come to PHKL, for example, then your cardiologist would be able to assess you and see whether you are a suitable candidate or not.